right, thank you very much, everyone, for joining us today. My name's Laura Katawaki, and I'm very honored to be moderating this panel on social prescribing. I work for United Way BC as a research and knowledge mobilization specialist, and as some of you may know, United Way BC is very involved in social prescribing in BC. I think probably a lot of people in the room might have a little bit of familiarity with the concept of social prescribing, but for those of you who aren't familiar with it, social prescribing is an intervention that originated in the United Kingdom, and it's really designed in order to help healthcare providers and social service professionals to support individuals who have needs that are non-clinical or non-medical in nature. For example, a person might have need for help with things like food insecurity, maybe loneliness and social isolation, housing needs. And these are things that the healthcare system generally isn't designed to deal with. So through social prescribing, healthcare providers or other social service providers can normally refer a person who might need these types of holistic supports. They refer them to what's known as a link worker or a community connector. And then this individual can help to provide them with the holistic care and support that they need, helping them to co-create a wellness plan and connect them with needed community resources. So with social prescribing, particularly within the last few years, there's really been, I think, an explosion in Canada. And so we've seen programs be developed in BC, Alberta, Manitoba, Ontario, and other regions. And with social prescribing, older adults in Canada have been identified as a particular population where there are potential social prescribing needs, because older adults might be facing chronic conditions, maybe they have multiple conditions, they need services from different parts of healthcare, housing, community, etc. So in some cases, older people might be ideal candidates for social prescribing interventions. And so today I'm very pleased that we're going to be able to have two presentations about social prescribing models in BC and Alberta. Now some of you might have already heard a bit about the BC model, maybe at the last Friesen conference, or I know some of the people in the room are our social prescribing agencies that United Way BC works with. So some of you might already be a bit familiar with it, but hopefully you'll be able to learn some new information today. And then we also have the Alberta model that we can learn from. And for United Way BC, we've had the pleasure of working really closely with our colleagues in Healthy Aging Alberta in the work that we do to support healthy aging and the community-based senior services sector. And Alberta has a very similar model to ours, so I think we often collaborate and we try and take inspiration from each other. So I'm really excited that we have our colleague from Alberta, Beth, who's going to share about their model so we can take away some learnings from them. So without further ado then, I'm going to introduce our first presenter. And so we're going to hear about the model in Alberta first. And our presenter is Beth Mansell, who's currently the Provincial Social Prescribing Project Manager with Healthy Aging Alberta, and you can find her full bio in the conference program. So I will turn it over to Beth.
So thank you so much for inviting me here. It's always nice to come to Vancouver on a nice sunny day. I live in Edmonton, so if any of you follow hockey, you'll know that the Oilers won last night, and I was very happy to see that. And then the other thing that I just wanted to say was Happy Seniors Week. All of our community-based organizations that we support are very busy right now hosting really great events for seniors in the community in light of Seniors Week, and I just wanted to mention that. So happy Seniors Week to everyone as well. Okay, so Healthy Aging Alberta, very similar model to Healthy Aging BC and the work that the United Way does here as well. I often joke that in Alberta, we're maybe like 5-10 years behind, maybe where you're at in BC with your community-based senior serving sector. So our work is supported through our government partners, and we're also backboned by the United Way of Calgary and area. And our goal over the past few years, we really emerged in 2020 after seeing the growth of the sector in BC and recognizing that there was no real coordination between community-based senior services in Alberta. And this meant that we weren't seen as a formal sector and we didn't have the ability to operate at a systems and policy level. So we connect and collaborate with this network of CBSS organizations to support and empower older adults' autonomy and well-being. We strengthen the sector to enhance organizational resilience and well-being. And we also amplify the diverse community voices, strengths, needs, and challenges for collective action as well. And so these are some of our strategic priorities that we've been working on over the past few years, really focused on building the sector, ensuring that diverse representation from the spectrum of CBSS organizations, so all the way from those grassroots coffee groups that are maybe operating out of a church basement once a week, all the way through to really large social service organizations that support older adults in the community. And we want to improve the capacity of all of those organizations to serve older adults. We're also collaborating to improve service delivery, systems integration, and navigation, and this is where social prescribing really fits in, along with our community and home support programs, as well as a rural assisted transportation program. So Healthy Aging Alberta is currently supporting work in over 50 communities across Alberta, either with social prescribing, community and home supports, or transportation programs. So why have we put our energy behind social prescribing? Well, I think it really fits well with the theme of this conference in terms of like that translation from research and policy into practice. And so community-based organizations had heard about social prescribing work that was happening in the UK, was happening in Ontario, and thought, we're already doing this, but we're not calling it social prescribing. We haven't formalized it, but essentially, this is what we're doing in community-based organizations. We're supporting older adults to get connected to different programs and services. We know that that has an impact on their health and well-being. And so how can we formalize this? How can we get investment for this? Because we think that it needs to be rooted in community as opposed to rooted within the health system. And so we know that all of those community-based organizations and services have that local knowledge and those relationships that really contribute to successful implementation of social prescribing. We think that by being based in the community, it's also a really, really great opportunity to incorporate asset-based community development, leveraging volunteers and all of those other things. And then the third piece, and I think probably the most important piece, is that we're hopeful that social prescribing will enhance our ability to increase resources and capacity for all of those programs and services that exist in the community. So as we know, a lot of the resources and the money sits within the health system. A lot of that investment goes into the medical care and the actual outcomes that people have. There's research that shows over 80% of someone's health is actually due to those social determinants of health. So let's create some of that shift and get those resources into those community programs that we know are having an impact on people's health. And so you can see here that our social prescribing ecosystem involves more than just the healthcare provider and the link worker that Laura had mentioned. And it really is a network. So we've got healthcare providers, link workers, we've got that CBSS sector and the other organizations, families and friends and natural support networks, and then also caregivers, and always making sure that that individual is at the center of our model as well. So this is what our formal referral pathway looks like in Alberta. So on the left side of the screen there, we have healthcare providers. And we've been very broad in our definition of healthcare provider. So it's anyone that's recognized as a regulated healthcare professional. Of course, a lot of the referrals do come from primary care, doctors, nurse practitioners. We also work closely with hospital discharge and transition coordinators. So when someone's getting discharged from the hospital, making sure that they have what they need at home so that they don't re-enter the hospital within a week or two. And then we also have great relationships with our home care case managers, who are often nurses. But in addition to those, it could be a pharmacist that makes a social prescription. It could be a physiotherapist, an occupational therapist. It could be a social worker that works within a primary care network. And so we're really trying to create that intentional connection with the healthcare system. So once that referral gets made, so that social prescription, which is in essence just a referral, that link worker who is employed by a community-based organization will meet with the older adult. They'll conduct that holistic assessment, co-create the goals and the care plan, engage in regular support and follow-up, usually for a period of 3 to 6 months. And then they also provide progress updates back to the healthcare provider. And that's a really important part of social prescribing. We're trying to create that integration between health and community. It's not just the one directional referral. We're really trying to create that feedback loop and make that link worker part of someone's care team as well. And then on the right side is all of those aging and community supports that the link worker is connecting with. So things like Laura mentioned, food security support, home supports like home and yard maintenance, housekeeping, connection to different financial assistance benefits and programs and things like that. See, now I'm managing the 2 screens, and somewhere along the way I'm going to mess up. So what is happening in Alberta? So our work around social prescribing is predominantly focused on supporting older adults, and right now I think that's just a reflection of where the funding is focused. Our provincial government and our other funder have been really focused on this work for older adults because they believe that that's where it has the most impact right now in terms of those reduced hospital admissions and reduced use in the healthcare system. But I do think there's a lot of potential, obviously, for it to apply to other segments of the population as well. It's predominantly driven from the community sector as well. So we've got community organizations that are really leading this work. If you look at some other provinces, like Ontario, social prescribing is really sitting within their health system. Our work, we're currently supporting 13 different communities across the province with implementation. So a mix of urban communities like Calgary and Edmonton, and then also rural communities as well. Each of those communities has at least one link worker. So in the larger cities, there's more than 5 link workers. They have some element of like a central intake and a triage system in the larger cities as well. And then our referral sources, right now, we're looking at about 30% of our referrals coming from home care, 25% from primary care, 20% from acute care, and then 25% from community sources. So that's the things like I was mentioning, like the pharmacists and community paramedics has been another really big referral source. And we do all of this through a coordinated provincial network. And I think there's a few key benefits of that. The first one being that we have a coordinated provincial data collection and evaluation framework. So I'll get to that in a few more slides, but we actually now have like provincial data on the impact that social prescribing is having in those 13 communities, which is really cool. It also means that we're able to do things like shared communication. So our communication around social prescribing looks the same in Jasper as it does in Calgary. And I think that's helping to ensure that it becomes trusted by healthcare professionals across the province. And then the third piece that I think is really, really beneficial is our community of practice. And so someone earlier mentioned community of practice model, and I think that's been one of the biggest strengths about doing this from the community sector. Our link workers that are maybe only one link worker in the community are able to connect with each other, say, hey, are you experiencing this problem? How did you navigate this? How did you manage that? And just seeing those relationships grow through the community of practice has been really, really powerful. Okay, so one of the things that we have done is establish these 8 principles for social prescribing. So we were noticing that when we first started this work, people were popping up and saying, well, we already do this, or we're doing social prescribing in our community. And my answer is always like, yes, you are, but what we're trying to do is formalize that work. And I think these 8 principles here really help to formalize what social prescribing is. So that first one being is that it requires a formal pathway to connect clinical care to community-based services. And this formal pathway is supporting evidence building for the role of community-based services in supporting health outcomes. The second is that it begins with an identifier who is considered a clinical professional. And so I know there's some other models where self-referrals are really accepted, and we are starting to move towards that, but we're also making that link back to healthcare as well. So we're calling it a reverse referral. And so if someone, they've come to a senior center by themselves and people think that social prescribing would be a good fit for them, that link worker is then also trying to connect with their primary care provider as well to make that connection and that integration. Social prescribing is a holistic, person-centered approach, so clients may have complex needs, but they also have unique goals, passions, and gifts that they're able to contribute as well. Social prescribing is strength-based, it's co-creative, it's community-led, so it's really about building individual and community resilience by supporting clients to become more connected to their communities and peers. It's not a one-size-fits-all approach, so some clients may require more support from a link worker to address multiple goals. They might be working with a link worker for 3 months, and other people might be working with a link worker for 6 months or 9 months. And it's also not a one-size-fits-all in each community as well. It looks a little bit different in a rural community than it does in an urban center. And then the last one is that it's rooted in health equity. So effective social prescribing includes working with clients to remove barriers that they face to health and well-being. I wanted to talk a little bit more about our link worker role as well. So our link worker role is very similar to the community connector role here in BC. And one of the things that we knew when we started our social prescribing program was that we were introducing a brand new role into the sector and into the system. And so we did a lot of work to develop a curriculum for the link workers and establish these core competencies. So we have these 5 core competencies here that were established through engagement with community-based organizations across the province. So that first one, making connections, this is really about that client relationship building, making referrals to other community-based services and supports, and then also building relationships within the community. So in a lot of cases, that link worker will actually attend community programs. They're getting to know the older adults that are attending those programs so that when they get a client coming to them, they can say, hey, I know you might be nervous about going to this program, but I already know Joe and Sally, and they're going to be there, and I'll come with you, and we'll help you get kind of introduced to that. The second competency around listening, so this is really about assessing client needs and engaging in that ongoing follow-up. The third one, self-reflecting. So I think a lot of this role is really about reflecting on different biases that we have, reflecting on practice and how we can improve things for future clients. Advocating, that's been a really big part of this role. So being able to communicate the value of the link workers' work to folks within the healthcare system, folks within the housing system, because it is a new role, we want to make sure it's really well understood, and the link workers are often the ones that are doing that kind of self-advocacy for the role. And then obviously advocating for clients as well. And then the final one around navigating. And so a lot of the role is around that service navigation and care planning too. So our link workers are complementary to allied health services. And so people often say, well, there's social workers that work within primary care networks, or there's social workers that work within hospital systems. And we want to make sure that we're not duplicating the work that's happening within the health system, but we want to highlight how these might be complementary and things that link workers can do that are different than those roles that exist within the health system. I also think that being community-based allows for more flexibility in scope. So for example, transportation to appointments or attending a first class or a group with a client like I just described. And then link workers are also able to increase awareness and capacity for these community-based programs and services that clients can be connected to. They kind of form like an informal community of practice, I would say, in their own community of knowing, oh, this program has a wait list, or oh, this program's going to be closed for a few weeks because the instructor's not there, or whatever it might be. I think folks working within the health system often don't have the trust and the flexibility to figure those things out. This is a slide that I wanted to highlight, because this is how we do some outreach and kind of training work within the healthcare system. So how does a healthcare provider determine if someone is a fit for social prescribing? So I think there's some prompting questions that we often suggest, but there's a lot more work that we need to do in this space, and we'll talk about that with some of the questions that we have in terms of the challenges of social prescribing, because we're coming at this from more of a community lens than a healthcare lens. But how often are you seeing family and friends? Are you having challenges getting from place to place? Are you able to access healthy foods that you like? What's your current living situation like? And do you need support accessing social services? So as I mentioned, we're working with 13 different communities across the province right now, and that's because that's all that our funding allows for. But there are a lot of other communities that have come to us over the past few years that are really, really interested in bringing social prescribing to their community and formalizing programs that they already have. So one of the things that we developed is a community implementation toolkit, and I think there's something similar that United Way BC has also developed as well. And ours is really a self-assessment tool to get communities to consider where they're at now and what they would need to do to be ready to implement successful social prescribing. As I kind of shared before, this work was happening for many, many years, and community partners were getting together, having those tough conversations with healthcare partners to figure out how do we get social prescribing in our community. And the point of this toolkit is to hopefully avoid that long, drawn-out process in other communities. So we've been working with different areas to kind of work through this toolkit, and they've said, well, we were thinking it would take like up to a year to fully have our program ready to go, but working through the toolkit meant that we could kind of start accepting referrals in 3 months. And so it contains resources for community organizations and healthcare providers to be able to feel confident that they can introduce social prescribing in their community as a pathway to connect older adults to those community-based programs and services. Okay, now more of the fun stuff, some of our results. So we started our programs in December 2022, and since then we've received over 3,400 social prescriptions. Of these, 2,700 have turned into assessments with a link worker. So just because a social prescription is made, it doesn't mean that someone's wanting to actually engage in that link worker support. But there's still a pretty high rate of folks and older adults that are willing to kind of go through that holistic assessment process. Currently, we have 24 link workers and 16 outreach or assessment professionals that are employed across those 13 programs. And for some of the outcomes, our evaluation framework, we focus on older adult outcomes, service provider outcomes, and then system outcomes as well. So this is for the older adults, where we have found that 89% of older adults have either had a stabilization or a positive change in their contentment with connections. And I should say the way that we measure all of our outcomes, we do point-in-time assessments. So we do an intake assessment when someone first meets with the link worker. We then do a check-in assessment at about the 3-month mark, and then a closing assessment at the 6-month mark. So we're comparing those responses over time. And then the other thing I should mention as well is that we also see stabilization as a positive outcome. So a big part of working with the older adult population is making sure that they're not declining and they're not needing to enter those higher levels of care maybe before they would have. 40% of older adults indicated a positive change frequency in their awareness of services, and 42% indicated a positive change in their access to services. 67% of older adults had a stabilization or positive change in their mental health, and 88% of older adults had a stabilization or positive change in their physical health. Focus group participants as well also noted that the program has increased their access to information, programs, services, and supports making daily living activities easier to manage. And they've highlighted that link workers are seen as a reliable source of guidance and reassurance as they navigate available community resources. So in terms of service provider outcomes, we are seeing our formal social prescriptions from healthcare providers continue to increase every quarter. So in our last quarter, we received referrals from 557 unique healthcare providers, which I think is a pretty great number. Early learnings are showing that healthcare providers have increased awareness of social prescribing and community services. We did a survey of healthcare providers back in December, and 55% agreed that they were spending less time with patients discussing non-medical and social needs, and 56% agreed that they had fewer appointments with some patients because their needs were being met elsewhere after starting to refer to social prescribing. So I think there's still a lot of growth in this area, but we are starting to see more of that inroads now with the healthcare system. And then finally, system level outcomes. A few things that I wanted to highlight here was the improved trust in referral pathways and improved working relationships between partners. So 89% of people agreed that referral pathways are improving, and 95% agreed that relationships between community partners have improved as a result of social prescribing. One area where we have limited data is around reductions in emergency room visits and hospital admissions. We are trying to track this, but we're relying on self-reported data for this. So out of clients that did respond to this question, only 10% had indicated that they had increased emergency room visits, and only 5% indicated that they had increased hospitalizations compared to the 6 months prior to receiving their social prescription. I think this is my last slide. So over the past few years of kind of going through the ups and downs of implementing a brand new program, I think there's been a few key things that we've noticed as kind of those key success factors for implementation. And the first one is a willing coalition or group of stakeholders from across sectors that have really built trust and respect for each other's role in supporting community health and well-being. And so some of the communities that had these really strong coalitions, they were able to hit the ground running with their social prescribing programs. Other communities where maybe this wasn't as strong, the referrals have really trickled in, and it's been much slower uptake. The second piece is a really strong understanding amongst all of the stakeholders of what social prescribing is. So really taking the time to understand what that referral pathway is going to look like, what kind of the elements of the program are, and making sure that everyone's on the same page about that. The third one is champions within healthcare that will promote this referral pathway to their peers. As I said, I think that's one of the challenges of coming at this from more of a community-based perspective. We'll often have people that go out and make presentations to healthcare teams, and then the referrals kind of tick up for a little bit, and then they drop off. And then they'll go out and make another presentation. Again, it'll kind of tick up and then drop off again. And so what we really need is champions from within the healthcare system that can promote this to their peers and make sure that it's an ongoing practice that's really embedded into their work. And then the last one is just that really well-resourced and also documented kind of directory of programs and services that are available for the link worker to refer into. And I think that's it for me.
All right, thank you very much for that presentation, Beth. It's always really inspiring to hear about the work that's being done in Alberta. Our next presenter is going to be my colleague at United Way BC, Prab Sandhu, who is the healthcare and community specialist, and she leads our social prescribing work.
Hi, everyone, and thank you, Laura. So I just want to start off by thanking Beth for her presentation. I know we've really appreciated the opportunity to be able to collaborate with Alberta as we continue to grow and just shape our respective models. There's been so much value in sharing what we're learning along the way, and there's so many parallels between the work that Alberta and BC is doing. So I won't repeat a lot of the stuff that Beth is saying, but I am excited to share a piece of the story from British Columbia. Last year, I was here with some of my colleagues to kind of talk about the rollout and the scaling up of social prescribing here in BC. And today I want to take a closer look at how it's been shaped. This presentation is titled Rooted in Community, because that's exactly what's defined BC's approach. It's been a co-created process from the beginning, grounded in relationships shaped by the people delivering this work and constantly evolving through feedback from community. So with that context in mind, I want to start by sharing a bit about how BC's approach has been shaped And while today's focus is on co-creation and how we stay rooted in community, I think it's important to acknowledge the broader network of learning and collaboration that's supported this work. Our earliest learning came from the UK. I think Beth mentioned that as well. In particular, the link worker model there, and just the emphasis on holistic person-centered support. That gave us the foundation to start from, but very early on, we knew that the approach had to reflect BC's own context. Our strong senior serving sector, the mix of rural and urban communities, and the community relationships that were already deeply embedded. So since then, we've continued learning alongside other provinces, and those relationships have been key. So Alliance for Healthier Communities in Ontario, for example, was incredibly generous in sharing insights and resources as we developed our BC Social Prescribing Implementation Guide. Alberta has also been a close collaborator. Their team really helped shape the development of our Community Connector online training modules, which are now publicly available and used across the province. We're also at the table nationally through groups like CISP, the Canadian Institute for Social Prescribing, where we're working with colleagues from across the country to build shared frameworks, surface best practices, and strengthen the evidence base for social prescribing. So while the BC model is grounded in local experience and leadership, it's also very much part of a larger learning community across Canada and even beyond. So this work began with 19 community connectors placed in senior serving agencies across BC. The idea was to create trusted community-based roles that could support older adults beyond clinical care. So taking the time, building relationships, walking alongside the seniors, navigating what matters the most. From the beginning, this model has been grounded in the strengths of the community-based senior service sector. These are organizations that have long-standing trust with older adults and a deep understanding of their own communities. We've also been really intentional about building partnerships with the health system, not just so the model could grow, but because health and community need to work together. We've done that work building out referral pathways, aligning roles, creating a space for shared problem solving, and that work is ongoing. We're continuing to shape this model through co-creation and collaboration at every level. From participants to community connectors, to our team at United Way BC, to health partners, academic collaborators, and government. The recent $304 million investment from the province to expand Better at Home, including the community connector model, reflects the collective impact of this collaboration. It's not just about scaling up, it's about government recognizing the value of community. A value that we've always seen, and one that has become even more clear through relationships, outcomes, and system shifts that are driven by this work. This investment is allowing us to nearly double the amount of community connectors in the province, and we're expecting to see close to 100 active across BC by the end of this year, hopefully. So that's a powerful moment, one that shows what's possible when community leads and systems are willing to follow. So co-creation is at the heart of how this model has developed and how it continues to evolve. It's embedded at every level. At the individual level, older adults, which are the participants, co-create their own wellness plans with community connectors. This isn't about directing people to services, it's about taking the time to understand their goals, their context, and what matters most to them. These conversations are grounded in trust, and they give older adults a real voice in shaping their own support. In many cases, their insights also influence how programs and partnerships evolve locally. At the implementation level, our communities of practice have been a cornerstone of the model. These gatherings bring community connectors and team leads together from across the province to reflect on challenges, share what's working, and help guide how this model is actually delivered. So what's been really powerful is how these sessions have created a space for honest dialogue, shared learning, and peer-driven problem solving. They're not just operational, they've become emotional and strategic anchors for the people doing this work. Many of the tools we use today, the onboarding resources, our intake forms, the wellness plan templates, these have been shaped directly through these sessions. Nothing is created in isolation. We test, we adapt, and we respond to what's happening on the ground. And this spirit of co-creation extends beyond the front line. We carry it into our partnerships with health, with academic collaborators, and with the government. Everyone at the table has played a role in shaping this model, and that's exactly how it should be. At United Way BC Healthy Aging, we often describe social prescribing as a way of integrating health and social support, empowering people to overcome challenges, and co-creating personalized solutions. And ultimately, it paves a structured path to health that involves the community, and this emphasizes a cultural shift in healthcare delivery across BC. So in addition to the communities of practice, we've hosted province-wide co-creation sessions. These have been game-changing for this work. These sessions brought together community connectors, agency leaders, health partners, and our team at United Way BC, not to receive a plan, but to build one together. And the impact has been real. These sessions have been a driving force behind how the model continues to evolve and scale. They've directly shaped things like clear role definitions, training priorities, and reporting tools that reflect what the connectors actually do. Reporting isn't just about accountability, it's about making sure that the work is seen, understood, and valued. Community connectors are doing deeply relational and sometimes even invisible work. If we don't capture that accurately, we miss its impact, and we miss opportunities to strengthen it. So that's why these sessions focused on creating reporting approaches that reflect the full scope of the role. From building trust, to mapping out community assets, to facilitating long-term change for participants. And what makes these sessions so powerful is how involved the connectors actually are. They don't just participate, they lead. They bring clarity to what's working, name what needs to shift, and help us build a model that's aligned with their real-world practice. These sessions are shaping not just the present, but also the future. As we look ahead to nearly doubling the number of community connectors, we're not just looking at scaling, we're refining. Evolving and building a more responsive system through this process. And so we're not tweaking around the edges, we're building a fundamentally different way of working. And I just want to share a quote from one of the connectors who took part in this last co-creation session we had a couple months ago. I think being able to express our thoughts about what would make the programs better and what new programs would need was so helpful. I loved being able to talk about our wishes for the programs. And that's what this is about, not just input, but vision and ownership. These sessions are helping transform a promising model into a movement, one that's reshaping how we think about care, connection, and community in BC. So one of the things that makes the BC model unique is that we've built community building directly into the community connector role, not as an add-on, but this is a core part of the work that they do. So while one-on-one support is critical, community connectors aren't just navigating individuals through systems, they're helping shape the systems themselves. Community building looks different in every region, but it always starts from the ground up. It might look like, starting a seniors walking group where none existed, collaborating with food banks or rec centers to make services more accessible to older adults, hosting drop-in spaces, tea socials, or lunch programs to rebuild connection, partnering with cultural groups to co-create inclusive programming. But the work also happens at a broader, more strategic level. Many connectors are helping to build and hold together local community collaboratives, bringing nonprofits, municipalities, Indigenous organizations, and health teams into shared spaces to problem solve and align around the seniors that they all serve. In some areas, connectors have brought physicians and health teams to the table, not just for referrals, but for real dialogue about how to better integrate care and community. Others have collaborated with academic partners, delivering presentations on social prescribing, contributing to training for health and social care professionals. And across the province, connectors are helping map community assets. They surface service gaps and act as a bridge between the sectors that have traditionally worked in silos. This kind of community development may not always show up in data, but it's the foundation for everything else. Without it, referrals don't land, programs stay underused, and older adults stay disconnected. And that's the shift that we're trying to make in BC. We don't see isolation, disconnection, or fragmentation as just personal challenges. They're community-level problems. And solving them requires community-led, cross-sector solutions. So social prescribing in BC isn't just about getting people to services, it's about building communities where people feel like they belong and systems that are better connected to support them. So to bring this work to life, I want to share a story that captures what social prescribing truly means, not in theory, but in practice. In Nanaimo, a community connector helped create a program called Kitchen Socials, a space where older adults come together to cook, share meals, and connect. It's a collaboration between the Nanaimo Family Life Association, physicians from the Nanaimo Division of Family Practice, and supported by us at United Way BC Healthy Aging. So what happens in the room goes far beyond lunch. During one of those gatherings, a physician sat down with participants, listened to their stories, and explored how social prescribing actually could be more meaningfully integrated into their practice. And one participant shared, "This was the best day I've had in a long time. I didn't know I needed this. I haven't felt this connected to people in years." And another participant who had initially felt unsure about even attending actually shared, sorry if I can find the quote, "I haven't talked this much in over 2 years. I haven't felt this hopeful and optimistic in a very long time." And these reflections speak volumes. For many older adults, isolation is deeply felt, compounded by retirement, maybe grief, mobility changes, or simply not feeling like there's a place to belong. Programs like Kitchen Socials help shift that. As the community connector involved reflected, "I've observed the joy, lightness, and hope emanating from seniors following their participation in a social prescribing activity. After being isolated for so long, these moments signify a newfound opportunity for older adults to build meaningful connections within the community." This is the impact, not just improved access to services or reduced loneliness, but real joy, renewed optimism, and a sense of being connected to something again. These stories remind us that social prescribing isn't just a system intervention, it's a human one. And it's working because it centers what truly matters to people: connection, dignity, and community. So we've talked about how the model has grown and evolved, but just as important is what we're seeing as a result of that work. For older adults, we're hearing consistent feedback about increased social connection, improved confidence, and a better understanding of how to access the supports around them. Participants have told us things like, "This gave me a reason to leave the house," or "I haven't felt this hopeful and connected in years." And these may seem small, but they're incredibly meaningful, especially for someone who's been isolated or unsure where to turn next. For community agencies, social prescribing has strengthened relationships with healthcare and increased their visibility. Many have told us that the community connector role has opened doors to new partnerships with primary care teams, health navigators, and other local service providers. Agencies are also feeling more equipped to demonstrate the impact of their work and to advocate for resources that reflect the complexity of what they're doing. And for healthcare partners, the feedback has been encouraging. We're seeing more appropriate non-clinical referrals being made and growing trust in the community connector as a member of the extended care team. In some regions, primary care teams are actively engaged in shaping referral pathways, offering warm handoffs and participating in collaborative planning with community partners. And what we're learning is this: when health and community work in alignment, we don't just connect people to services, we strengthen the entire system around them. And most importantly, we build support that feels human, responsive, and grounded in what matters to those people. So as I mentioned earlier, we're now in a period of major growth. With the province's recent investment, we're working toward doubling the number of community connectors by 25-26, with about 100 connectors working across BC. But this isn't about increasing just the numbers. The success of the model so far has been built on strong local relationships, co-creation, and responsiveness. And that's something that we're committed to preserving as we grow. So while we scale, we're also investing in the pieces that hold this model together. Strengthening community collaboratives that bring agencies, health partners, and others together around the shared goals for older adults. expanding knowledge sharing networks so connectors can learn from one another and adapt to what's emerging in their regions, and continuing to refine tools and supports that offer structure without rigidity. Because what we've seen is that the local flexibility that we have is essential. So what works in Nanaimo might look very different in Terrace or Surrey, and that's not a weakness, that's a strength. So this next phase is really about balancing that consistency with responsiveness, scaling up without losing the relational community embedded heart of this work. And that's what we mean by staying grounded while we grow. So if there's one through line in everything I've shared today, it's that collaboration has always been the constant. This model wasn't developed in isolation. It was built through shared ownership, not top-down mandates, with community connectors, agency leaders, healthcare partners, researchers, older adults, and policymakers all playing a role in shaping what this work looks like. And those collaborations are continuing to deepen and expand. At the provincial level, we've been invited to take part in the Ministry of Health's home health transformation work, where we're helping ensure that community voices are a part of that future of aging and care in BC. We're also actively involved with regional and local collaboratives across the province. As I mentioned earlier, these aren't just about coordination. They're where we see partners coming together to respond creatively and collectively to what older adults are experiencing on the ground. On a smaller scale, we are seeing new relationships form all the time between connectors and family physicians, housing advocates, rec centers, food programs, and more. These local partnerships are where innovation happens. Nationally, we stay connected to the broader conversations through CISP, and we continue to share insights as the work grows across Canada. And internationally, we're still in conversations with some of our colleagues in the UK where this all started, continuing to share what we're learning here and what makes the BC model unique while still learning from them. But at the core of all of this, big and small, are the community connectors. They are the glue. They're the reason that these collaboratives even work. They bring lived experience, trust, and the insight that grounds this work in reality. So while the model continues to grow and systems continue to shift, the core principle remains the same. When we build together, and when connectors are at the center, we build better. Okay, so I just want to thank everyone for engaging with us and for listening to my presentation. And thanks, Beth and Laura. It is really meaningful to be back at the Friesen conference where I presented last year. And even since then, the growth and momentum in BC has been incredible. This model continues to evolve through collaboration across sectors, and it's exciting to see just how much can happen when community stays at the center. And I really encourage everyone to go to the United Way BC booth and find the social prescribing implementation guide. It gives a really in-depth about social prescribing in BC. And yeah, thanks for listening.
All right, thank you very much, Prab. And I'll just note, I think we have given away all of our social prescribing implementation guides at the booth that are printed, but you are able to find it online if you're interested. Now, I think we do have about 20 or so minutes for questions. So I'd like to start off just asking a couple questions as the moderator, and then we'll go to audience questions, as I'm sure that some of you have things you'd like to ask as well. So to start off with, one of the things that I think really is unique about both the BC and Alberta model is they are very strongly embedded in community. You do see some other social prescribing initiatives where it's based in the healthcare system and the community connector or link worker might be hired directly by them or working in a primary care office or that sort of thing. So I think there's a lot of strengths of having a model that's based in community. But then, of course, one of the challenges is if you're not embedded directly in the healthcare system, you need to build those relationships. So I was wondering if both of you can speak about some of the challenges that you've had with building those referral pathways and relationships with the healthcare system, as well as some of the successes that you've seen.
Sure. I can go first. Yeah, I think I alluded to some of those challenges in my presentation, but I think what we see, obviously, the healthcare system holds so much power, and we're just little community-based organizations coming and saying, hey, listen to us. We have this solution to all of your problems, when we truly, we think we have the solution. We don't truly know like the realities of a doctor in primary care. We haven't worked in those systems, right? So I think sometimes we present and we share and we're like, this is going to be the silver bullet and it's going to be so great for you. And it's hard to get them to actually be like, yeah, you're right? It is. And so I think continuing to, like I said, build those champions from within the healthcare system, like that peer-to-peer approach is so much more powerful. So I think that's been a really big challenge. But then successes, like I said, in those communities where there are some of those groups that have come together, I think we've noticed that the healthcare stakeholders coming to the table and the community stakeholders coming to the table, they're just coming to the table as community members, especially in the rural communities. I have one link worker in a small town called Sylvan Lake, which is close to Red Deer. And when they were starting their program, she's like, oh, I need to get into the healthcare systems and so on. And then she was like, oh, there's a doctor that's one of the parents on my kid's soccer team. Like, I'll just talk to them there. And that was really successful for them, but that's not likely to happen in those larger urban centers. So, yeah, I think some of those successes, I would say, have been more so in the smaller communities where people are really coming to the table just as community members. Yeah, they have this hat, but they just really want the well-being of the older adults in their community to improve.
Definitely a lot of the same stuff that Beth has said. We face a lot of similar challenges here in BC and a lot of the same successes. But one thing that I found that's been particularly successful and it's been the advocacy. So that's, through our academic partners, through the work of the connectors, and it takes time to build that trust. But where we're at now, we actually have some of our health partners approaching us because they have that level of that understanding of social prescribing, and that came from that advocacy, that education. And then another big challenge that comes with that is health in general is such a beast. There's so many moving parts, and you speak to someone who's so enthusiastic, and then their role changes. It's not relevant anymore. They're gone, and that's gone with that person. So then it takes time to build those relationships, and it takes time to really have that sort of embedded within our systems. And I think we're really seeing sort of that growth happen exponentially, especially within the year. I know some of my colleagues and some agencies and some of the connectors will agree that this year has been crazy, and I think that's in part with the investment from the government, from the ministry. It adds that sort of validity and trust, again, with our health partners.
All right, thank you very much for those answers and insights. So if anybody has a question, please feel free to put up your hand.
I'm Shelley. I'm going to be in the next panel, and I work at South Vancouver Neighbour House, and we've been supported very generously through the United Way. We started a social prescribing program. We've been up and running for a year. One of the big challenges in building that trust with health is the confidentiality. Like they still, I know you're nudging them, but there's still reluctance to trust that information is going to stay with the community-based service provider. And I know we talked to you about that, and I don't do the social prescribing, but this person who does reports to me, and we keep pushing that. And we can't do it. We cannot do it. It needs to be done by United Way and through the ministry. So that's one thing it's simplified in an implementation guide and in a presentation. On the ground, that's extremely challenging for community-based organizations. My other point is just in the presentation, the first presentation, you mentioned that you're hoping that some of this work will leverage resources coming to the community for new programs and services. And that's wonderful. And I know that our United Way is asking us to track when programs are full and taking wait lists. But the reality is there's no funding that I can apply for. I'm the money chaser. I have to try and catch up with the seniors because they have the ideas and then I have to find the money to implement the programs. But there's nothing for grassroots organizations anymore to apply for when they want to do these programs. So I thought, wow, that kitchen table series is fantastic, but somebody's paying for that. That's the reality is it can't be absorbed into social prescribing. I know my social prescriber was ready to start programming, and I said, that's not our role. You're going to refer to those programs, but there are wait lists. And my plug is that neighborhood houses do a lot of wonderful work, and I'm going to talk a little bit more about that. But the senior centers, the community centers, the rec centers, those that are municipally funded are in a much better situation to be able to do some of this free programming, but they don't do it. There's a cost associated with everything. So again, I love where you're going with it, but it's not as simple as that. We need funding to be able to do the programs that get identified through this social prescribing that those isolated seniors want, and we need to deliver those in the places in which they can get to easily. So out in seniors' buildings where people aren't getting out, not the community centers or the rec centers, people walking through those doors do not have the same level of barriers. So I know we're talking a lot about our experience, and I appreciate that, but it's the lived experience of the older adult and the barriers that they face that we really need to be addressing. So I know I'm preaching to the converted. I know that, but I see my funders at my table accidentally. But I just wanted to point that out. I do think it's a wonderful, much needed program, but it's not quite as simple as what you guys are suggesting. Anybody have any money at any of the other tables? I'll come sit with you.
I'm not sure where to start because you are preaching to the converted, and I think that's part of this work, though. Like, we all need to be building that evidence base. Like, I know that there's not enough money for community-based programs and services right now, but I think all that we can do is highlight the impact that those programs are having in the hopes that we're able to generate some of that investment into the future and as the population continues to grow. One of the things that we've built into our next round of funding is some of that kind of, I don't want to call it discretionary revenue, but a pool of money that link worker or the connector can tap into when they do want to leverage some of that asset-based community development, or they do have ideas that are coming to them from older adults in the community. That was something that we heard in the past 3 years that was missing. Link workers would be working with older adults and they would say, well, I really want to start a knitting group, but we don't have any money for supplies. Okay, well, now hopefully you can have some of that access. I know that's probably not the answer that you're wanting, but I think all that we can do as researchers, as academics, as community providers is continue to advocate for more of that funding, and we can't do that alone. And we also need to be connecting with our health system partners and having the health system partners advocate for that too, because as I said, that's where all the money lies. All of our public taxpayer dollars, I don't know the exact percentages, but there's a huge amount that goes into the health system. And if our programs are having a bigger impact on someone's health and well-being than prescriptions are and as surgical interventions are, then we need to be advocating for that. So, not the answer that you wanted, but the one that I'm going to give.
If I may, just one quick question, and thank you for those great presentations and the comments we heard earlier. Just to segue on those comments, I think in order to expand the social prescribing programs, one of the things that's going to be necessary is to show that they're effective. And I know, Beth, you shared a little bit of evaluation data, and I was just curious as to what the plans are for expanding that in Alberta, and then in BC, what the plans are for evaluation of the program.
Yeah, well, I can speak a little bit about BC. Obviously, Beth will speak to Alberta. So when we did launch the social prescribing demonstration project in BC, which is around 2019, 2020, there actually was a plan for a very robust evaluation of that and also two other programs that were launched at the same time. And we were going to collect a lot of demographic data, health use data, etc. But then the pandemic came when our programs were being launched, so most of them were delayed being launched. And then when they did launch, they weren't necessarily doing social prescribing at first. Instead, they were doing an initiative called Safe Seniors, Strong Communities, which was intended to address those immediate pandemic needs that people had, because at the time, they couldn't come out and meet with a social connector, a community connector, or go do things to build social connections, but they needed things like prescription drop-offs, grocery drop-offs, etc. So that unfortunately kind of put those plans for the evaluation, kind of kiboshed them in terms of we weren't able to do that evaluation that had been planned. In terms of our evaluation and data collection, as Prab has mentioned, we do a lot of co-creation work with the community connectors, and so we collect data through that. We also have regular outcome reporting that the organizations do as well about the outcomes and impact of social prescribing in BC. And then there has been a recent call for proposals. I guess it would be from it's not called Michael Smith Foundation for Health Research, but whatever its new name is, from Health Research BC, I think it's called now. Yeah, so there was a recent call for proposals for different work around home and community and support needs for older people. And so there was a LOI, I believe, that was submitted, and there's plans to do some research with various academics and put in a proposal for that to do some more fulsome evaluation of the social prescribing model. And then there have been various other research projects that we have done and partnered with various researchers on. And I don't want to take up all the time because I want to make sure Beth has time to talk about Alberta's work because it's very interesting. But if anybody does want to talk with me about evaluation and research, please feel free to come and speak with me after the presentation. But I'll let Beth have a few minutes so we can wrap up on time.
Yeah. Our evaluation approach has been very developmental. We've co-created our evaluation frameworks as well with those community-based organizations too. But it's complex. You're trying to evaluate the impact of the referral itself. You're trying to evaluate the impact of the relationship with that link worker. And then you also have those hundreds of different programs and services that someone could be connected to. So I think we've tried to simplify social prescribing evaluation, but it's not something that can be easily kind of wrapped into a nice little package. And then I think the other thing that we often hear is like, well, we want Alberta-specific evidence or we want Canadian evidence. And I think we're a little bit behind in that right now. So I know there's a lot of academics in the room, and if social prescribing is something that you're interested in, I would definitely recommend that, we get some people on board for some more research studies around social prescribing, because I think that's what's needed in Canada right now.
All right, and are there any other questions? I do see a Gloria.
Just a quick question. We're coming on Elder Abuse Awareness Day. So my question is, who hires and screens the connectors to ensure the safety of seniors? And I don't know, maybe I missed it, but what is the profile? Is the average connector a senior themselves? Or somebody in middle age? Is this, it's job creation in a way. If you're going to put up another few hundred of these individuals, do we know who they are in terms of socio-demographics?
Let me start with the first part of the question is who pays their salaries? So United Way BC has a funding relationship with the agencies, and so the community-based agencies are the ones who hire the community connectors. And that's why we say it's rooted in community, is that it's really based on those local needs and based on those agencies that are within those communities. Now, we do provide some guidance, whether that's through the Canadian Institute of Social Prescribing. They've built a core competency framework around what a community connector or a link worker should look like. And then we do provide guidance around some of those hiring practices, that job description, and then who the connector actually is. They can be a senior themselves. They are somebody who, again, is deeply relational, rooted in the communities, and that with the seniors that they're serving. A lot of the connectors we have are retired healthcare workers, retired nurses. Some of them are retired social workers. So it comes from a broad range. But it really is that relational and community rooted person that we look for.
And then the elder abuse part, in our training curriculum, we do have resources around kind of that screening for elder abuse. In Alberta, we have what's called the Alberta Elder Abuse Awareness Council that has some really great resources and modules. And so the connectors or the link workers are really trained to be making sure that they are kind of identifying those situations and making sure that they're referring on to those specialists, because that link worker role is not a specialist in elder abuse.
All right, and we are now at 3:45 p.m. right on the dot. So in that case, I think I'll wrap it up. I'd just like to thank Beth and Prab for their presentations, and also the audience for the great questions. And feel free to connect with us if you're interested in learning more and want to ask additional questions.